Hi, I'm Kristy Fuller, and today I thank you for attending the webinar. And today we're going to talk about supporting successful feeding outcomes in the NICU. So let's take a look at the objectives for today's webinar. I'm going to talk about supportive pre-feeding and feeding readiness strategies that will provide a foundation for optimal oral feeding performance. I think this is really at the foundation for improving outcomes and taking on a more preventative model or a preventative approach to feeding issues in the NICU. We're going to talk about how we recognize the role of assessment, how we use assessment in supporting successful feeding outcomes. We're going to identify strategies to minimize stress during feedings. And then we're going to talk about some interventions to promote pleasurable, successful feeding experiences. So I look at feeding as a developmental process, and this process is obviously interrupted when an infant is born prematurely. Our role as care providers in the NICU is to support the natural developmental trajectory of the infant. We need to support infants' naturally developing skills. So once they develop the skill set for feeding, then they're going to become more efficient. But they have to make those synapses and global neuronal feeding maps so that they know how to do this well every single time. And as a baby becomes more efficient, eventually endurance will follow. But we can't expect them to start out doing well and start out with this difficult task when they don't have a good foundation for the skill. I think we don't spend enough time as therapists or as nurses in the NICU setting a good foundation. And so when we set the foundation, then their skills are going to develop. We also have to take a look at the environment. And what kind of environment do we have in our NICU that supports the family to be there? Because they are the most important ones. The baby is not expected to be separated from his or her mother. Too often we as experts with good intentions end up setting up a situation that makes it difficult for the parent to feel competent. We need to work through the hands of the parent. So why is setting the foundation for positive feeding experiences so important? Because we want long-term success. I pulled a recent study from 2017 just to share with you as a reminder that our babies don't have great outcomes when they go home, and they continue to struggle with feeding difficulties. So when we take a look at this study, the prevalence of feeding difficulties in NICU graduates is 20% higher. And this is probably a modest number because the tool that they use to measure feeding difficulties maybe wasn't as sensitive as hopefully some of the tools that we're going to have in the future. So like I said, it's difficult to study long-term outcomes because there's a lack of valid and reliable measures. But the good news is there's some new assessment tools coming out that I want to share with you today. For infants younger than 7 months, there's a parent report tool, the NEO-EAT breastfeeding. There's a screener plus the tool, and NEO-EAT bottle feeding. And there's a screener plus the full tool. And those are going to, some of the information right now for those tools is really in press, so it might be hard to get your hands on the actual research article, but stay tuned. Look for the work by Britt Pados, and she is referenced on this slide. And then in addition, for infants older than 7 months, the parent report tool is the Child Oral and Motor Proficiency Scale called the CHOMPS and the PD-EAT. So I'd encourage you to just watch for those tools coming out because I think those will really help us have a better feel as therapists or maybe nurses working in NICU follow-up clinic. What is the outcome of our infants and how are they really doing? So it's really important for us to do a valid assessment so that we know where are these babies in the NICU and beyond, and how can we partner better with parents as they're trying to learn to care for this infant that maybe isn't progressing the same as maybe other children that they've had, or it just may be a whole different path that this baby is taking. One of the things that I think is really good is to take a look in your NICU and observe how the parents are caring for their infant and feeding their baby. Parents model what they've been taught. So I think we need to be really careful in terms of how we're doing things, and that's why consistency is so important. I've also referenced an article here by Britt Pados from 2016, and it's a nice overview of the assessment tools available for evaluating oral feeding in infants younger than 6 months. And so basically the key tools that are available that I would just highlight is the PIBS for breastfeeding. There's the NOMAS that was developed by Marjorie Palmer, and the Early Feeding Skills Assessment Tool. The important point I also want to make about assessment is it does decrease length of stay, and it's been shown to reduce hospital readmission rates when we do a good job assessing what's going on from a feeding standpoint and then being able to address that. So as far as a standardized and reliable tool that's available for our infants in the NICU, that tool is the Early Feeding Skills Assessment. And so if you haven't had a chance to get your hands on this, I would encourage you to watch for the new updates, because just recently they've completed psychometric testing on the EFS. I've been using this tool for over 10 years, and it is fabulous. And I think that you would also find it really, really helpful. I also contributed to collecting data on this tool to contribute to the psychometric testing. So I'm probably a little bit biased. Okay, so let's take a look at just assessment in general. So if you don't have a familiarity with an objective tool like the Early Feeding Skills Assessment, just take a look in your setting and say, you know, what do we want to see as outcomes? Where are we struggling? So are we having babies that are taking lots of partial feedings rather than, and it's taking them a long time to achieve full feedings? How do we compare with the research in terms of the number of days it takes to achieve full oral feedings? Or what's our discharge data look like? There is literature out there to review, and you can compare and say, you know, where are we at? What about looking at just some stability signs and saying, you know, our babies seem more stressed, or they have faster heart rates. Our babies are sleepy. They aren't waking up very well. You know, so taking something like that and saying, let's measure some outcomes, or let's do some comparison of our babies with what's in the literature. Okay, so turning the page here, I want to encourage us to look at behavioral observations. And so the Early Feeding Skills Assessment uses behavioral observations to assess the infant's current skills, emerging skills, and challenges. Feeding is a dynamic process, and the infant's skills can change from one feeding to the next and within a single feeding. And that's one of the many challenges of feeding, is that it seems like what I might see when I come in at noon is different than what that nurse saw in the night or the next at the next feeding. And so today we're going to talk about identifying infant signs of organization or disorganization and ways to promote optimal skill development during feedings. And basically what I would say is some of the things that I'm talking about from a behavioral observation standpoint are taken and put into an objective tool format with the Early Feeding Skills Assessment. So we're going to primarily base this on the work of Heidi Alls, and so the synaptive theory of development. And so she talks about the wiring of the brain is important for the development of stability and organization. And out of her work developed the NIDCAP training tool. Our interactions with the baby can disrupt these subsystems, and the goal is to support organization and the infant's natural developmental trajectory. So let's take a look at these 4 subsystems, and I'm going to review these in the context of feeding. Babies communicate to us through these behavioral subsystems, and these were identified many years ago by Hailey Alls, and these are dynamic systems. So the first is the autonomic system, and this is the core. And if your autonomic system is unstable, nothing else is going to work well for you. So we're talking about heart rate, breathing, oxygen sats, even skin color, visceral stability, being overall comfortable. Then we look at instability of the autonomic system. What happens when your heart rate is just going way too fast or your heart rate drops? What about oxygen saturations that are up and down? Color changes. It's important that we pay attention to these subtle changes. Sometimes the beginning of a problem you can see right around the eyes or around the mouth. So paying attention to times when babies begin to show these signs that my autonomic system is not functioning very well right now. Breathing too fast is something really common. I think we sometimes expect babies to attempt feeding when they are just breathing too fast. And that's like us running up a set of stairs and then trying to guzzle a glass of water. We can't do it. Signs of increased work of breathing, head bobbing, quick little breaths, grunting, stridor, nasal flaring, paying attention to if a baby's arching away, chest retractions. Sometimes parents will say they don't like it, they're moving away, but explaining that to parents that this baby's moving away for a reason. Breathing pauses, hiccups, gasps, cough, any stomach discomfort. Nobody wants to eat when their tummy doesn't feel comfortable. And a baby that's just more twitchy or showing some tremors, those are signs of instability in that autonomic system. I learned many years ago from a wonderful teacher, Robert Beecher, that the most important item to assess during feeding is breathing. And most of what a baby does during feeding is related to airway maintenance and/or protection. And I think keeping this in mind every single time you come to the bedside helps change the way you look at the feeding experience. And it also helps in explaining what's going on to the parent, helping parents be able to assess breathing. Does the infant stop sucking to breathe? Do they stop soon enough? Do they take adequate, full, quiet breaths? Because if breathing is going well, feeding is going to go so much better. Basically, it's impossible to feed well if breathing is not going well. I also want to make a comment, probably before we move on here to the motor system, on just feeding infants at younger ages or on pressurized breathing support. That's concerning to me. Why not wait for better stability? To me, it just seems like the disadvantages are great, and the potential for that infant to have long-term issues with feeding is so high when they're put in such a stressful situation to try to coordinate feeding when they really don't have their breathing system stabilized. Okay, let's talk about the motor system. Tone, movement, and posture. And if we look at this little infant, she was a term baby, which you can tell because of that nice physiological flexion that she has. So we want to see our babies have some maintaining of a tucked body position with support, positioning them so they can have their hands by their face and mouth, grasping and holding on behaviors, showing some energy during caregiving. If they can't maintain some energy during caregiving, it's pretty tough to do well with feeding. rooting and searching, which we're going to talk more about, and knowing that an infant has to be able to suck on their pacifier or nuzzle non-nutritively at breast without a cost to their autonomic, motor, and state systems. Okay, so this little person, you can see how nicely positioned this little girl is. She's got her hands by her face and mouth, and she's supported nicely with tucking. On her side, she doesn't have to work up against gravity. She also has the ability still to have some freedom of movement. I think sometimes we swaddle too tightly, and then infants don't have the ability or freedom to move, and we certainly don't want that to be the case. Instability in the motor system. So movements away from midline, arching, flailing, limp or flaccid, lower tone. The finger splay is a classic sign of stress. Gape face, delayed or absent rooting, and limited non-nutritive sucking skills. So this little guy was an early one, and you can see that on his back, he doesn't have a lot of options. He's pretty much flat on the bed, not able to keep himself tucked and supported. So again, that calls us to provide support to help him with being able to maintain his hands to his face. And this little guy is finished. He's definitely done with his feeding. You can see it in his eyes. You can see it in the low tone around his face and mouth. Okay, so now the last one. We talked about autonomic, we talked about motor, now we're going to talk about state. So asleep, drowsy, quiet alert, crying, or unavailable. And then what are the transitions like between these systems? And we know, any of us that are called into at a feeding time know how quickly these states can change. We can have a wide awake baby who falls asleep really quick. And so sometimes then the baby doesn't get to attempt a feeding, even though we thought initially they were ready to go. So when we have some stability in the state system, we're seeing restful sleep, smooth transitions between sleep and wakefulness, the skill of being able to wake up with cares and then eventually wake on their own. I think sometimes babies are being woke up too many times instead of allowing that natural skill set of waking on their own. I think it's really important that we don't ignore sleep and that we recognize that in order to develop feeding skills, infants need restful sleep. We can't expect them to feed well if they're tired and worn out. So that might be something to take a look at in your setting. Is everybody on board with sleep? And are we allowing infants to wake up on their own? Or are infants always being woke up? Being able to sustain alertness for 5 to 10 minutes. That's important. Can't participate in a feeding if you can't maintain some alertness. Being able to be available, be consolable. Now, instability in the state system, those are those rapid transitions between awake and sleep. And certainly we see that as something normal in the NICU, but again, expecting that infants can maintain a certain level of wakefulness or they're not going to be able to feed well. They're just not ready. There are those infants too that are awake, but maybe they're struggling to breathe, have a faster breathing rate, and so they really don't have any energy. They're really not that available. Lastly, when we put all these subsystems together, so we take autonomic, motor, state, then we look at attention interactive system. And so that's some eye contact, that visual integration, the settling to the caregiver. These are skills that we see in older infants. They have to be able to engage and get stability in that core autonomic system, in the motor system, and the state system. This is the place at which we want to engage babies in feeding. Some of the regulatory behaviors that we hope to see are babies showing some hands to face and hands to mouth when they're well supported. hand clasping. This is a good picture of foot clasping, that first picture at the top, holding on and bracing their feet. And we have to positionally give them opportunities to use these regulatory behaviors. We have to set them up for success. So on the flip side, there's disorganization. So this is probably what we see most of the time, is inconsistency. And so we want to look at those times where we can support optimal organization. But often our infants are showing some level of instability in the three subsystems, and we might see a lot more stress behaviors. And we have to figure out how we're going to respond to make this a positive feeding experience. We also need to ask ourselves, why are they struggling, and what could we change? I like to divide up some stress signs so that we're on the front end of looking at stress. So at that first eyebrow raise, when you're feeding an infant, you say, ooh, did they miss a breath? How's breathing going here? So you're responding before you get a desaturation, before the heart rate drops. Now, certainly there's situations I'm feeding a baby and they have a bradycardia episode, and honestly, if I was videotaping and went back and looked at the videotape, maybe I could have picked up on a sign that bradycardia was going to happen, but sometimes it's really tough. And so I think that's another time when working with parents and helping them identify these early signs is really helpful, but also helping them understand that sometimes a heart rate drop does occur, or sometimes a desat will occur, and we weren't able to prevent it in the feeding situation. But certainly, looking at these early signs, a look away, blinking behavior, looking worried. Something's not quite right. They don't look very comfortable. The finger splay, like I said, if they miss a breath, I often, in teaching parents, will partially undo the front of a baby's sleeper so that it's easier to look at breathing. Encourage parents also to put their hand on their infant's back so that they can feel. And we always talk about looking, listening, and feeling for breaths. And then what if I hear a yelp or gulping sound or what if I'm seeing loss of milk? How do I respond? And we're going to talk about that. So when we think about putting it all together, this little guy obviously is not well supported at this time, but it only took a little bit of help from his mom to come in and gather him up, and there you go. He's looking pretty organized in all his subsystems, and he's attending and ready to go. So when I am problem solving and thinking about setting the stage for feeding success, I go through the 4 standards of developmental care. And I say, what am I doing to provide a supportive environment for this infant? Is this individualized for this particular baby? How am I working collaboratively to make sure we're all on the same page? And how am I supporting the parent-infant relationship? I want us to really think about preventing feeding problems and facilitating better long-term outcomes. The 4 standards really work as a great guide to intervention, and working in the NICU is all about teamwork. So we have to work together, and we have to all agree that long-term outcome matters. So when we set the stage for success, we need to be thinking about the baby's experience in the moment. What are we doing to make it pleasurable, nurturing, stress-free, and so that we're facilitating positive brain pathways that eventually lead to those global neuronal maps? This has to happen every single time. And feeding happens 8 times a day. So we have to think about what is the experience for this baby each time they're offered bottle or breast or tube feeding, and they need full attention from their caregiver. sometimes that can be an issue in this age of technology, just the nature of being in the NICU. There's lots of distractions. And so it's so important that we are engaged and attending to the infant at the time. I love this quote from the NAN textbook. Ensure that every feeding experience is a positive, pleasant, and nurturing time, regardless of the size or age of the infant or the route or volume of the feeding. This has long-term implications. Children long-term can have sensory sensitivities, sensory defensiveness, rigid perseverative behaviors around meal times, and these are really difficult to reverse. And there's the financial cost, but there's the emotional cost to the family. And if you think about all our holidays, all our gatherings, they're all around food. And so we want to set our babies up for the best possible set of skills for feeding so that when they go home, they are enjoying birthday parties. They are participating in all these family gatherings. So this is our goal. Feeding should be fun, pleasurable, effortless. The early feeding experiences shape these babies' long-term behaviors. And they're hard to undo if a baby doesn't get a good foundation for pleasurable feeding experiences. And babies will learn to avoid feeding when they aren't able to keep themselves safe or comfortable. So now we're going to talk about ways to set a good foundation. For babies that are under 32 weeks or they're not orally feeding yet, this is a chart that my colleague and I developed to organize our thoughts about pre-feeding experiences. So we took touch, smell, and taste. And the goal is that every baby has all of these experiences from birth. This is how to prevent feeding difficulties. And it may be different for you to be thinking about these babies aren't even feeding yet. And that's the point, is that we're setting this up from birth. So we want infants to have, again, uninterrupted sleep because they have to conserve their energy in order to grow and in order to have enough energy to wake up around feeding times and begin to show that readiness. And they need supportive positioning. Niles Bergman has just done tons of work and research on skin-to-skin holding and the benefits. So there's lots of literature on that. I think this Weissman study is interesting. He looked at organized versus active/disorganized sleep and did a 5-year follow-up. And the babies that showed organized sleep at 37 weeks had improved executive functioning, improved symbolic competence, improved verbal IQ. And so it is super important for brain development to have good sleep. And I don't want us to underestimate that. If there's one change that I would say makes a huge difference in outcomes, it's skin-to-skin holding. And so take a look at your practices. How long, how often are babies being held skin-to-skin? There's a few pictures. And dads obviously can hold skin-to-skin too. We encourage that. Rooting. It starts with supportive positioning. Using the sense of smell with colostrum or milk on the baby's own hands or pacifier. Timed with tube feedings. Touching the, helping the baby touch their own hands or the pacifier to their upper lip or cheek. If there's no response, continue with skin-to-skin holding, or infants can do some non-nutritive nuzzling at mother's breast, and maintaining that supportive positioning with touch of the baby's own hands to their face. They don't get enough of that because so often they get in a position where they can't get their hands back by their face. And consider what practices in your NICU might interfere with rooting behaviors. I've heard some therapists say to me, oh, they don't root, they will root. If we support that normal developmental reflex of rooting, babies will root. And we may not see a response if an infant hasn't had a lot of opportunities, but given the opportunity and given the support, they will show rooting. Unless there's something that maybe is neurologically wrong with that infant. So let's talk about what pleasurable tube feedings look like. Staying with the baby so that we're optimizing their comfort. I know it's very difficult in busy nurseries to have someone be with the infant every single feeding, but really that is the ideal standard. And so that's the importance of having an ICU where parents feel welcome. So the parent is there to support their infant. And if they can't hold for some reason, the baby's too sick, they can do some hands-on holding within the incubator. A volunteer cuddler is also a great way to help with holding if the parents aren't available and say nurses or therapists, staff in the NICU are not available. This cuddler program can be something else that is very helpful to support infants to have a pleasurable tube feeding. What is learning like if a baby is left alone in their bed for a feeding? That's not what feedings are about. Feedings are an interaction. And even if that infant is sleeping, they may show some signs of stress as their tummy starts to get full and benefit positively from your touch or maybe a slight reposition. No caregiving tasks should be completed while a tube feeding is running. So here's a couple of pleasurable tube feeding pictures. A mom of some twins, and she's holding them both skin to skin. And then this little guy wasn't able to be held for his tube feeding, but his mother's hand is able to support him with his hands to his face and mouth. He's able to have the smell of milk on his finger, maybe get a taste that would be safe for him. So just thinking about, again, we're setting the foundation for pleasurable oral feedings, and so tube feedings need to be well supported. Let's take a look at an NICU feeding readiness criteria. This is a criteria that my colleague and I developed and has worked well, and I'm going to provide some feeding readiness articles on the Dr. Brown's website, so you're able to access those. We had established these guidelines and then took another look at them based on some of these newer articles that came back and that came out, and have continued to use this chart, and it's worked quite well. A NICU feeding readiness criteria supports consistency among caregivers. It guides the initiation of oral feeding, so it answers the questions, when is this baby ready to start? It also helps us determine engagement during a feeding. So if a baby starts to show that they had readiness signs and then we're not seeing readiness, we know we need to stop or not continue. Or maybe just a baby needs a break and then they could continue. It helps facilitate objective decision making. So it's not one nurse saying, this baby's not ready, and then another nurse saying, oh yeah, they're ready to eat. Or the parent asking, can we start feedings? And nobody really has a reason why or why not. It's also been found to shorten the hospital stay when we use an objective criteria. So let's go back and take just a look at this one more time. So it's divided into the 4 subsystems: and autonomic, motor, state, attention, interaction. And the expectation is that to begin feedings, the infant would have steady breathing, heart rate, oxygen saturations when held. with a rate below 70. And then that rate would also stay steady and oxygen sat stable with non-nutritive sucking. So if you can't suck on a pacifier or glove finger, nuzzle at breast safely, then you're certainly not going to be able to begin oral feedings. And then looking at the motor aspect of things, what kind of energy level do we see with tucking when they're provided some support? And how good is that baby able to do with waking up on their own and staying awake for around half of their, waking up on their own for around 50% of their caregiving times and staying awake for 5 to 10 minutes. And then also taking a look at how they do following just regular care. So a diaper change, are they completely worn out, or do they still seem like they have some energy? So this provides a really nice guide. And one of the things that can also be done is you can create it into something that nurses can use to record on their shift. Did this occur, did they meet feeding readiness once on my shift or 4 or 4 times on my shift? So that's helpful too, because then you can get a feel for, over a 3-day time period, are they showing some consistency with meeting feeding readiness criteria, and then ultimately ready to begin oral feedings. So again, we want pleasurable oral feedings, supporting breastfeeding, waiting for rooting, autonomic motor and state system stability during cares, when held, with non-nutritive sucking, and then ultimately while feeding. And this is helpful for parents too, because maybe their baby is doing really well with skin-to-skin holding, but having some instability with non-nutritive sucking. So then it's clear to share with the parent, okay, the next step is being able to be stable with non-nutritive sucking. Maintaining supportive positioning, slow flow for bottle feedings, and making sure that we are doing everything we can to have the parents present and being able to feed their baby as often as they can. And that the experience is baby-led. So ideally supporting breastfeeding, then the mom is present. And looking at what are your hospital's policies on breastfeeding, and how do we support breastfeeding, and are there things that we can do to do better? If we're introducing bottles too soon, I think that takes away infants' energy and can be stressful for both the mother and for the infant. So I think we need to make sure that we give the baby time to develop their breastfeeding skills before we're introducing bottles. And so ideally, no bottles until about 50% of the intake is taken at breast. And that we're not expecting premature infants to breast and bottle feed at the same feeding. With term infants, a lot of times that happens, and the babies do fine. But our premature infants usually are too tired to be able to successfully do that. And so taking advantage of the use of the NG tube or OG tube. And then I do have a site here, 10 steps to successful breastfeeding, baby friendly for the NICU. And there's just some really good suggestions in that article about how do we best support breastfeeding. And this little guy is an early baby that did fabulous with breastfeeding. So often the question comes up, what do we do about the baby that is not rooting? We need to wait for a wide opening of the infant's mouth. Adjust positioning. Will the baby root on their own hands? Making sure, sometimes having the smell is important. So the smell of the milk, giving an opportunity to repeat the touch cue. And if a baby has no response, to provide that feeding via tube. It's unsafe to feed our premature infants that are not rooting. We need to make sure we're positioning them with their hands by their face, so they're getting that touch input. and lots of skin to skin, lots of non-nutritive nuzzling at mother's breast. I use a rule, 3 strikes, you're out. So giving the infant 3 opportunities, and then if they are not showing rooting, they are not showing readiness. So just remembering rooting is readiness, and rooting sets up for safe feeding. Elevated sideline. It's important to use this as a way to slow the flow and to support overall stability. So this little guy, you can see the bottle is held horizontal. The ear, shoulder, and hip are in alignment. The baby's able to bring his hands to his face easily. And from a postural support standpoint, he doesn't have to be wrapped in a really tight swaddle, because the mere fact that he's on his side allows him to stay pretty tucked. It's also really easy for the person feeding to feel for breathing, to look for breathing. Overall, I think at first, the transition to maybe feeding and sideline can be a little challenging, but a lot of times what I do is I say, tuck them in like a football hold, and then turn the infant to their side, and it's real easy. The rationale and the research is out there for the importance of elevated sideline, and so I've cited a couple articles here, but it slows the flow, improves airway protection and breathing, fewer signs of behavioral stress, which is huge because we don't want our babies to be stressed during feeding, and we want to optimize their energy, safety, and overall performance. So sideline is an easy change to make if this is something that is not always common practice in your setting. The benefits of slow flow. Thank goodness for Dr. Brown's. I am not paid to endorse their product during this webinar, but I can wholeheartedly do that. I've been using the Dr. Brown's bottle nipples for all the infants that are fed in the setting where I work in an NICU, and can say that it's a fabulous product. It's reliable, the flow rate is consistent, families love it, nurses love it. So I would encourage you to look at the Dr. Brown's product for the benefits of providing slow flow. The other tool that you can do if you don't have the option of using the Dr. Brown's is to make sure that the bottle is held horizontal and only filling the nipple half full, in addition to elevated sideline. Matching the flow rate to the infant's ability can eliminate the need for external pacing. And I know external pacing is something that is used quite a bit, and I'd like us to take a new look at that. I've cited some different studies where you can look at the comparison of different bottle nipples, but huge benefits of slow flow: decreasing stress, supporting the development of suction, improving the handling of the bolus, eliminating milk loss, multiple swallowing, improving the safety of swallowing, not gurgling, no yelping, no gulping. And these are items that I listed on signs of behavioral stress. So if you can get rid of some of these signs of behavioral stress just by using sideline and a slow flow bottle nipple, you're already improving the experience of that infant. The other thing I want to comment on is the development of suction. I think we need to pay more attention to babies developing good skills. They have to have good suction. And if they use compression, they won't develop good suction. And this happens when the flow rate is too fast, or when they have a soft latex nipple where they can use more up-down motion rather than suction. Other benefits of slow flow are improving the suck, swallow, breathe coordination. You slow things down, you give babies more time to get their breath in and to integrate that breathing within the sucking burst. So sometimes you can see an even more mature suck, swallow, breathe pattern by slowing the flow. And I think we used to think that premature infants needed a faster flow to make it, quote, easy for them. But what we found is that if we slow things down, babies do even better. It's not harder for them, it's actually easier for them. And it improves their physiological stability. So I want you to consider eliminating external pacing. It's very difficult to be consistent among caregivers. It's a source of stress and confusion for parents. It's developmentally not natural to put the bottle in and out. Babies should be able to regulate their breathing, whether they use an alternating pattern where they take a few sucks and then they take a few breaths, or whether they're able to put those breaths in between the suck swallows. External pacing is often poorly timed. The bottle is removed too late, or even if the bottle is removed, the baby doesn't initiate a timely breath, so they're still having too long of a breathing pause, and it really does disrupt that suck, swallow, breathe rhythm. So what are alternatives if I say don't use external pacing? Allow some time for that infant to mature. See if you can give that baby 3 to 7 days of tube feeding and supporting non-nutritive experiences, because within that time frame, often they'll mature enough that they will start to regulate their breathing as long as they're provided a slow flow bottle nipple. And often the Ultra has been the ticket, that using the Ultra Preemie Dr. Brown's bottle nipple allows the flow rate to be slow enough that they can begin to regulate their breathing on their own and do not require external pacing. The other situation where I think external pacing is needed and may be required for a period of time is with those babies that just get incredibly hungry. And so they just suck, 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 and forget to breathe in the first 1 to 2 minutes of feeding. That's different. It's not a requirement of regulating their breathing throughout a feeding. And so we do need to impose some breathing breaks in a regular way to prevent instability with that transition from non-nutritive to nutritive sucking. But I do hate to see infants that are feeding and requiring external pacing every single time they are feeding. Instead, I'd like that to be reconsidered and just to say, you know, that infant is too immature at this point. Let's give them a little more time to mature, because their experience is going to be so much more positive and baby-led. So just to summarize, supportive feeding experiences begin at birth and they support the infant's own developmental trajectory. They provide an environment that supports sleep, growth, and brain development. So we're always looking at how can we help this infant get opportunities for skin-to-skin holding and support that parent to be the consistent caregiver. Consistent pre-feeding experiences. So rooting is huge on the list, and the development of rooting and opportunities to root. Having a set feeding readiness criteria or feeding readiness guidelines. Using breast milk and breastfeeding, supportive positioning, elevated sideline with hands to face, and slow flow to develop suction. We need to accurately assess and interpret baby's cues, so minimizing behavioral stress, looking at the 4 subsystems and identifying behavioral stress. Sometimes I will make a chart, organization, disorganization, and just list different behaviors that I see. If you're using the early feeding skills assessment tool, then you have a more objective assessment of that infant's signs of stress and organization. Stopping at the first signs of fatigue so that we're not continuing in a feeding that is not going well for that infant. That is not helping that baby's brain development. That is not helping them develop skill. Rethinking language that says, oh, my baby's just being lazy, or I got him to take. It's not about that. It's about the infant being able to organize himself or herself to feed well and safely and comfortably. And so if an infant is not doing that, something's not going well for them. And we have to figure out, what skills are they lacking? And that's where an objective assessment tool is very helpful in figuring that out and saying, why aren't they doing better with this? Avoiding the use of imposed interventions, jiggling, twisting, pulling the nipple in and out, jaw, chin, cheek support has no place. Nipple switching is not helpful. So we need to make sure that we are supporting consistent learning. And thinking from a long-term perspective. Every feeding is a pleasurable, nurturing experience every time. And what practices are we using that will support future feeding skills? So we need to really think long-term and help our babies have pleasant experiences when they're feeding. I think sometimes we forget that feeding is 8 times a day. Feeding is more than feeding and nutrition. It's a relationship between the mother and the child. And when a baby is not feeding well, we are all searching for answers. We can't blame a mother for trying to help her baby survive any way that she can with the knowledge that she has. And so I think we need to work together as a team to help understand feeding issues and to support the family and to support the caregivers so that we're all having a positive, pleasant feeding experience. This quote, I think, is really sums it up nicely. It says, a baby's ability to eat and a mother's ability to feed her baby are at the heart of who she is as a mother. A majority of the time together in the first year is spent feeding. It is a powerful social and emotional learning experience, and if positive, they develop synchrony. So I will close with that quote and just keeping in mind that we need to look at feeding experiences from a long-term perspective and think about preventing feeding issues. Thanks.